welcome to South Coast Matters. My name is Paul Letendre.
And I'm Julie Taylor. And South Coast Matters is a public access television program where we bring together civic leaders, business leaders, and citizens to discuss how we can make a positive impact on our South Coast communities.
And we try to have some interesting conversations with some interesting folks. We try to learn a few things in the meantime. Today's interesting guest is Don Berwick.
And let's see, Don has quite an impressive resume. So in 2004, he was knighted by the Queen of England for his efforts to help reform Britain's National Health Service. And in 2010, you had a recess appointment by President Obama to be the administrator of the Centers for Medicare and Medicaid Services, and called the second most dangerous man in America by former Fox News host Glenn Beck. And in 2014, you also ran for governor of Massachusetts.
Good credentials to run on, being downgraded by Glenn Beck. Don earned both an MD and a Master's in Public Policy from Harvard and the John Kennedy School of Government. And he did those both in the same year. God bless him. So showing off a bit there, Don. And he then was founder and chief executive officer of the Institute for Healthcare Improvement. And it's a not-for-profit organization. And in his spare time, Don doesn't have any spare time. Thank you for being here, Don.
Nice to be here, Paul.
We want to query you. Don's been a proponent of single payer, which is not socialized medicine, he tells me. But it sounds like socialized medicine to me and those folks that sit at the diner with me in the morning. So tell me why single payer is not socialized medicine.
Well, you've got two functions that need to be served. One is you have to buy care. Someone has to buy it. Like here, we use insurance companies to do it. And then you have someone to give care, like my doctor, my hospital. I mean, socialized medicine, as I understand it, is when the government, your government, owns both functions. It's the buyer, but it also is the seller. It owns the hospitals, it runs the hospitals, pays the doctors. I mean, it employs the doctors. And there are countries in the world where that's true, where healthcare is a government function, just like building roads is a government function. It's both paid for from taxes and supplied by the government. Single payer, I imagine, means different things to different people, but I think the best way to understand it is that the payment side, buying the care, is all consolidated in one pot, one function. For example, like President Obama asked me to run the Centers for Medicare and Medicaid Services. So that's our nation decided in 1965 that if you're 65 years or older, your insurance is government insurance. The government is the payer. You paid for it in your taxes, in your Medicare taxes. And so when I sat in my office in Washington, my job was like buying the care for 100 million Americans. About 50 million Medicare beneficiaries, 50 million Medicaid. So every day I'm there saying, all right, these are my beneficiaries, I got to defend them, I'm going to buy the best care I can for them. But the care I was buying wasn't government care, it was care from the same doctors or hospitals as anybody. But it's consolidated payment, okay. And that has advantages.
So instead of paying insurance bills, we'd be paying more taxes.
You'd be paying less money total, but you have to there'd be some organization you'd be paying to. It could be a utility structure, doesn't necessarily the government, but yes, there'd be one place. Right now, the money you're paying for your health care is coming from all these different places. So it's coming from out of your paycheck if you're
And the first person to get their hands on are the insurance companies.
It all goes to the insurance companies. We have hundreds of insurance companies. So it gets really complicated. Every insurance company makes up its own rules for coding and billing. Your doctor has to fill out this form for this one and this form for that one. I mean, it's a mess. No, try to read your insurance policy, your health insurance. You tell me what it says. I can't read it.
When I can't sleep, I do that. I usually get 2 sentences.
And it makes the payment system really complicated because all the money's coming in from these different sources. And the data show that the complexity of that, it costs a lot. Some people say that it's as much as 20 or 25% of the total bill. Just to do the math, if we're spending $3 trillion more or less in healthcare in America, 25% of $3 trillion is $750 billion. That's bigger than the gross domestic product of most countries. That money's going into paper pushing because of the complexity. Plus, the complexity has one other problem, which is a little hard to explain, but it's like a problem of accountability. Let's say I don't like my insurance. Let's say I think you ought to cover this thing. Who do I talk to? You tell me the phone number that you can call with your insurance company that gives you voice when you think something's unfair or when they ought to change it. There is no such phone number. It's all chopped up. So it's complicated and chopped up.
Let me back you up a bit. How much, it's 20, 25% of, so how many billions was that?
Well, if I'm using some of the estimates, but if you say, let's take 20%, which is a common
lowest
number. 20% of 3 trillion is $600 billion.
600 billion. We have
Paper
300 million people in the country. So you're talking $2,000 per person.
For pushing paper. That makes sense because we're spending about $10,000 per person for healthcare.
Right.
These are all hand-waving numbers. We don't really know exactly, but the research is pretty clear. What I knew, for example, in Medicare, so I ran Medicare, and we had overhead, administrative costs. We still had to have paper. So my total budget for administration, total, was $8 billion, and we were spending $800 billion. So 1%, we had a 1% rate. So sometimes I say, we're probably wrong. We didn't count all the money, so let's make it 3%.
Still.
So look, 3 versus 20. The Obamacare, the Affordable Care Act, put some restrictions on. One of its good components was it went to the insurance industry, Obamacare says you can't spend more than 15% of your budget on administration. So they're trying to take them down from 20, 22 to 15. Massachusetts, we have laws that keep you to 10%. But still, the difference between 3% and 15%, that's a lot of money.
Because in Massachusetts, a portion of that, if the insurance company goes over, goes back to the people who are paying the insurance rates in order to keep that down. Now, that's not part of the Affordable Care Act.
That was in a special, that's strong legislation in Massachusetts that was trying to make insurance even more efficient. And our insurance companies in the state, they are more efficient. They don't spend as much on administrative costs.
Can an insurance company survive on 10%?
They're doing it. Some are.
Are they profitable?
Yeah, well, I'm not a particular enthusiast of bashing insurers. I know these people. You know, they're like the rest of us. They go to work trying to do a good job. They're playing the game. What I say is they're playing the game the way we wrote the rules. So when when the batter swings the bat legally, you can't blame them for doing that. That you wrote the rule. You don't want to swing the bat that way. Change the rule. That's how I think of the insurance thing. But right now, the insurers are playing a game which allows them to have very high overhead and, by the way, very high profits. And insurance companies make a ton of money on profit. And you go to their buildings, you'll see
I've seen some spectacular buildings. Yes.
And we're paying for it. Carpenter. Here, in the South Shore, you're paying for it, Carpenter. It's coming out. Look at your paycheck. There's a line there. It says deductions for health care. So you're buying that Oriental carpet. If you don't like it, let's change the rules. Let's have a system which is much more sleeker, which is more oriented toward you. And you do need the insurance. In the end, even in single payer, we need to kind of hire back some of the insurers to do you still have to pay the bills to do the administrative work, but that's what led me to it. I didn't, when I started to run for governor, I wasn't a single payer advocate. I hadn't been. For a number of reasons. What pushed me was understanding the finance of the state. We have so much we need to do for our well-being, in our education system, our transport system. Our transport system is broken. It really is in trouble, and we need to get back where it needs to be in housing and in criminal justice reform. But where do you get the money? I guess we could raise taxes, but I'm not too enthusiastic about doing that too much, if at all. Why not find the money where we're wasting it? And, hey, guess where it is?
One of your opponents, Evan Falchuk, he says a lot of the same things you say, really, but he likens it to your house's roof is leaking on your home, and you fix it, and it's no big deal. But if you let it leak for 10, 20, 30 years, it becomes a big deal. And that's what we've done with our transportation system, our highway systems.
Pay now or you pay later. We keep kicking the can down the road, and it's partly because healthcare is absorbing the money. I want to be clear. I don't think that single payer or any payment system is perfect. I can tell you all the problems that would happen in a single payer environment. It's not perfect. I would just rather trade off those problems for the ones we're living with now, if we could do it, get it done politically.
Now, the VA system would be kind of an example of
Yes.
socialized medicine, where the government
Yes.
owns it and provides it.
VA and the Department of Defense, Military Health Command.
Right, TRICARE. So we've seen the problems with that and the bottlenecks that occur trying to get the care delivered when you have a large amount of people just descend on the system where they weren't really prepared or didn't have the funding for it. So if we were to go to a single payer system, there are ways that it may, like we have the polarized Congress now, just trying to pass a budget, which hasn't been done in a long time. So how could that actually hurt delivery of care when it comes to funding? Couldn't that hurt the people that least can afford to be hurt?
Yeah, well, let's take it one at a time. The VA system first. I'm a fan of the VA. I've worked with them for years and years. Something went off the rails there. There's no question they lost track of waiting times, and there was some cultural issues there. But if you look at the overall history of the VA for at least the past 20 years, its performance has been very, very good.
With a population of very complicated histories, they've been able to do it quite well.
Chronic illness, a lot of
Their budgets
behavioral
have
problems.
been, my dad passed away a few years ago in a VA hospital, and I can't say enough wonderful things about them.
And you're not alone. They did tell you other stories. Patient safety. We learned in about the mid-1990s, really, or early 1990s, the lights got turned on. We learned how unsafe healthcare is. People really get hurt a lot. Mistakes in care, really hazards.
Lifting patients is big.
The workforce, that's nurses. The injury rate for nurses in Maine is higher than for loggers in Maine.
Oh,
so
yeah,
we have
that's
a workforce
terrible.
that's unsafe.
Yeah.
So what do we do about it? Well, a lot of hand wringing, a lot of, well, we really can't. But meanwhile, what did the head of the VA do? It was amazing. He hired an astronaut, and he brought him, Jim Bajan, and he brought him to the VA. He had him report directly to the director. He said, you made space flight pretty safe in very tough conditions. Help us in healthcare. He actually had a plan within, a year or two. They had organized patient safety work in the VA that was stunning. I'm not saying they got perfect. I'm sure there were errors there, but you see, you had a responsible person with a budget to run a system who could say, we need help and help it. The rest of the system had a lot more trouble doing that. Later on, in a way, they were victims of their own success. They opened the doors so wide. They really brought people in. They moved from hospital to ambulatory care. They had an amazingly generous drug benefit, medication benefit. So people flocked there, and Congress didn't provide the resources needed to handle that volume, and things got out of whack, and then other things went wrong. But I don't take that was.
They were slow to embrace technology too, weren't they?
No,
they were
no.
early to
they?
embrace.
Yeah.
They had one of the first electronic records ever.
Okay.
By the way, that record's owned by the American public. It could have been the American public's record if we wanted. They were pretty innovative, but there were problems. My other point about this is, look, bad management is bad management. You have to. It doesn't matter if it's a private company, a government agency, or the VA. It's hard to run complex things. So, but that doesn't mean.
It can be hard to run simple things.
Sometimes when
Really?
in my life. So I think the VA story has a lot of positive in it. But again, I'm not really talking about that. I'm not saying we need the VA for all Americans.
Right.
I'm saying we need Medicare for everyone. Look, I went on Medicare. I was the first administrator to go on Medicare. Now, I've got my problems with Medicare. It's sometimes a little hard to use, and it's a little bureaucratic sometimes. But oh man, when I went to the assistance center in my town because I couldn't figure some stuff out. Oh, they were just so anxious. They didn't know I was, but so anxious to help me. And My wife and I don't worry. We're not going to go bankrupt now because of health care. Why? Because Medicare exists.
See, that's what everyone should have the privilege of not having to worry or sweat making the payments or, geez, I can't buy a car because my health insurance is 15% of my income, along with my 50% of my income is housing, so what's left over?
Yeah.
It's really crazy.
It's not perfect, and obviously single payer is a big stretch politically. This country doesn't seem to have the will right now. Maybe there's some mixed models we could be looking at, whether we do it at the state level, I don't know, but it would be simpler and more responsive, I think. Meanwhile, look, we got to work with what we have, so I'm not throwing in the towel on helping make the current system better. That's what my career is, but that's where I came from on that.
And like it was pointed out to me when they first instituted Social Security,
Yeah.
it's taken 80 years of trying to tweak it and continually try to make it work better. So we're into the Affordable Care Act now just 6 years.
Yeah,
so it's going to take some time to work the kinks out.
Yeah, Julie.
Yeah.
I mean, I remember when I was a kid when Medicare came in, but my father was a doctor in a small town. He was pretty skeptical. I mean, anything you want, he thought maybe a good idea, but he was worried. Now, try to take Medicare away from the American people. I mean, I don't care who you are, you can't do that because people know it's just socially just, it's guaranteed, you've got it, and you can count on it. Why would we not have that for all of us? The transition would be difficult. I don't want to make it sound simple. It wouldn't be.
No, what would make it so difficult? The fact that so many citizens have it in their head that, single payer is, that means socialized medicine, like you pointed out.
I don't know anyone who
taxes
loves
are going to
their
be
insurance
crazy.
company.
Right.
Yeah. Well, it's difficult now because of the way the resources are distributed in the status quo, by which I mean the insurance companies. They're very, very wealthy. Again, I want to say I'm not into bashing them. I don't regard them as bad guys. I regard them as guys playing the current game.
Right.
But they have a lot of money. So when you try to say, maybe we should expand Medicare to cover more people so that they can have the same benefit I do now that I'm 65. You read and all the newspaper ads start, they're going to tell you, doctor, what to do, and government's going to run your care. No. But they can buy the ads, and they capture the airwaves. And unfortunately, the way we built.
Weren't you going to be head of the death squad? I seem to remember.
Yeah, I mean, there's a good example where we have so much knowledge about care and advanced illness. We know the kind of compassionate care people want. People want to be home, not in the hospital. Most people don't want the kitchen sink at the last stage of their lives. They want to be able to talk to their children. And the actual thing I believe is you should get anything you want. If you want the kitchen sink, healthcare is a human right. You should get it. But most of us don't. But you watch the system, and it was just completely, overwhelmed by technology. So we didn't have really good ways to help people who are really getting toward the end of their lives. And then you had this absolute drivel, this hogwash, death panels. No such thing. That was created out of the air, and the politicians ran with it, and the public got duped, and we had this period of fear. Luckily, we're over it now. I think we finally are starting to mature, and we're going to have much, much better care for you when you're really, really, really sick.
And that's now a reimbursable event with your doctor to discuss those end-of-life issues.
Yeah, when I was there, the administration wouldn't even take that on because the airwaves have been so seized by this vicious rhetoric. Now, with the passage of 4 or 5 years, now now it's been passed, and when your doctor sits down with you and says, I want to make sure when you're approaching the end of your life, you're healthy now, you're fine, but when you're approaching the end of your life, tell me more about how you'd like it. You want to be home? Would you like us to do absolutely everything, even if it has no hope, because you want that? I'll follow your directive, but tell me what your directive is. And that conversation now can be supported. Your doctor actually is supported to have that conversation. And I'm glad about that.
Well, it was illegal for a time, wasn't it?
I know it was illegal to have the conversation, but it wasn't compensated for.
Okay.
It wasn't, your doctor would have to do that out of just generosity or whatever. But no, now it can happen. And you don't have to have that conversation. You don't want to. There's a wonderful thing your viewers should all know, called the Conversation Project. I don't know if you've heard of this, but my organization, IHI, Institute for Healthcare Improvement, was approached by Ellen Goodman, the Pulitzer Prize winner, who had the idea that communities ought to start to foster the conversation, which is, how do you think about your own future, especially if you get very ill? And the family should have that. And the Conversation Project, now you can go to conversationproject.org, you can find it online, and there are resources there to help you deal with this difficult but necessary part of our lives. And I think we're maturing now.
I hope so. It is illegal still for to prescribe medicine to end someone's life, even if they request.
Physician-assisted suicide is
Yeah,
not legal in the states. Some states it is. It's not in this one.
Yeah, it is legal in some states.
Yes, Oregon famously has that
Okay.
provision now, and so they're accumulating experience on exactly how it's used. My view is that the best investment for our state is in great care at the end of life, which means hospice available to anyone that needs it. And hospice can be absolutely, it's a wonderful resource in the community to help families and people cope with this life stage.
Is it financially feasible?
It depends on the payers, and in Medicare we've pushed hard over the years to make hospice more and more available, and it's getting more available. And I think the doctors and nurses and staff of these organizations ought to be applauded, because they're doing some of the hardest but most meaningful work that we could ever want to help us through these difficult periods.
Okay, to be the devil's advocate now, hospice, they'll keep people alive or keep them plugged in to keep collecting the check, even when they...
Yeah, look, I haven't met a sector of our economy where there aren't jerks and thieves. I mean, we have a small number everywhere, and they're in healthcare too. And I think a lot of regulation exists that makes things hard for us because we're looking for the jerks and thieves. That's what happens when you go through the scanner at the airport. You haven't got a bomb, but somebody might. So that way of thinking, it produces this very difficult environment. But I'll tell you, through my whole career, including when I was a regulator in government, most doctors, most nurses, most people in healthcare, they really want to do the right thing. They want to heal. That's why they chose to do what they do. And yeah, they want to make incomes, but we can trust our workforce quite a bit. And one of the great penalties we're paying now for this complexity and, surveillance that's going on is the workforce is getting demoralized. Doctors and nurses are finding it harder to do their work exactly when we need to make it easier for them.
Now, the Medicare doctors who provide that for patients, it seems like lately they've been reducing how much they can get reimbursed for that. Does that contribute to that?
I'd say readjusting, maybe. For example, the way we set up Medicare was very oriented towards specialty care, procedures, and hospitals. So if you look at Medicare has rate setting. There's a schedule that says if you take out a kidney, that you get paid this. If you counsel someone on smoking, you get paid that.
Take off a nose, you get paid that.
Yes. If you look at that, you'll say, well, wait a minute, we're paying the procedural people a lot. I mean, even simple surgeries get lots of money, whereas, say, counseling visits or primary care encounters, kind of not so much. And so there's been some effort, and it's in the Affordable Care Act, but it's been ongoing otherwise to rebalance so that we get more oriented around health, prevention, counseling, mental health care, really important. And so for some people, yeah, they're seeing the rates go down because they're taking that money and putting it over where I frankly think it probably will do more good often. And doctors are very fortunate in any specialty today. They're in the higher income levels of our society, and my view is if we need to rebalance to get people the care that really, really, really can help them, I think that's good to do.
Well, that's one of the exciting things from my point of view about the Affordable Care Act is it seems to be more of a focus on prevention, keeping people healthy before it gets out of control. And we do have a lot of high-cost medical conditions, diabetes, heart disease, that kind of thing in this country. And I just think that's been really great. But now, like you just pointed out with providers, it seems like we're going to be short of doctors that would provide family medical, family practitioner, primary care, that kind of thing.
Yeah. The Affordable Care Act, it sounds like you may have read it. That's you seem to know it very well. Yeah, it has some great stuff in it on prevention. For example, I got to sign the regulation that finally has Medicare cover prevention pretty broadly. You know, Medicare, when it was created in 1965, didn't cover prevention. It was an acute care program. So we actually had to write laws and regulations more and more to cover it. And then finally, the Affordable Care Act finally says, yes, if it's effective, it's covered. First dollar, no copay.
Yeah.
So that's great. It also has prevention funds. Massachusetts is actually taking advantage of some of that. These are funds for communities to engage in obesity initiatives and prevention. I think it's going to be very important with our opioid epidemic. So that's really important, that kind of thinking differently. In terms of primary care, I have a little different nuance there. Yeah, I mean, I'm a primary care doctor. My father was. So I have great respect for it. But I think we need to think a little more broadly about what I'll call primary care systems. Because
You speak primary care, we're talking GP, but
it's the first person you see.
Okay.
It's like it would be a
General
GP,
practitioner, yeah.
it would be an internist, a pediatrician. Sometimes people think OBGYN because women tend to use that as their main. It's your first place where you go.
Okay.
They're the ones who, when you have a pain, say, oh,
Who's your doctor?
yeah, who's your doctor?
Yeah.
And then when you go see your doctor, that he or she will be the person who say, oh, you need a specialist. So that's primary care. It's the front door. And it's been undervalued and underpaid generally, and it's a little undersupplied. I think the way out of that, and most people probably disagree with me, but I'm not sure it's a lot more primary care doctors. We have a lot, and but what I see is what happens when nurses, for example, nurse practitioners, advanced practice nurses, community workers. There's a workforce view of this that I think is pretty neat. And when I was in practice in pediatrics, I worked with nurse practitioners. And I hope it's not revealing a secret that I often went to them, and they weren't coming to me saying, what should I do? I was going to them saying, what should I do?
Yeah.
And so if we think more about teams, Julie, I think that we can actually solve this problem with team-based thinking.
I totally agree.
The other thing is telemedicine. I mean, man, I am so excited about what I'm seeing in forms of telemedicine. Like, you know, the geography goes away as a barrier. You can actually get help from the greatest expert in the world if you have something specialized, or if you're in a rural area, you don't have to get in a car or plane. You can get the help. And the experiments going on now in telemedicine are some of the most thrilling I've seen, and it's what I want as a patient. I don't want to have to travel if there's another way to get the same help.
Right.
You mean like show me your elbow or show me...
I'll be actually tomorrow. I'll be flying to New Mexico to keynote a meeting of the ECHO project in New Mexico. It's telemedicine, but there you have a doctor, Dr. Aurora happens to be his name, who's an expert on treating complex liver disease. And he used to have all the patients come to Albuquerque to take care of him. Not now. He set up the ECHO project, and he can coach every little tiny clinic in the state on caring for very complicated illness. And he's got the data, the results. The results aren't as good. They're better because people locally can adjust their work to local needs, and the costs are much lower.
You know, I'm like sort of a healthcare policy junkie anyway. I read about it all the time because I think it's pretty fascinating, and I think most of our viewers.
You're a policy junkie, Patty.
I know, but healthcare is pretty exciting, and I think for me, it's made me feel a little more enlightened when I'm trying to go through this whole process, because it's not as scary as, well, I don't know anything about healthcare, but there's lots of good places you can read information out there. You know, I would encourage people to take a few minutes and, you know, follow a site, or, you know, go to Kaiser Permanente and look at their stuff. Go to Centers for Medicare and Medicaid Services. The state website as well has great information, so you can start to teach yourself.
I'll say IHI, my organization,
IHI.
IHI. You go to IHI.org. Welcome. I mean, you'll find so much there that will help make it less mysterious. If it's mysterious, it shouldn't be.
Right.
This stuff it's about you and your health, and you can control it.
That's right.
Thank you, Don Berwick. We're so grateful for you coming here in this awful weather. My name is Paul Letendre at South Coast Matters. We want to thank folks at TCAM Studios, our home away from home. They've done a great job. Ben and who else have I got to thank? And Kim, thank you. Kim
And
Murphy.
Walter. Don't forget Walter.
And thanks. Come again.
All right, and there's our email. So good night.